Good evening, everyone, and thank you for joining us tonight. For those of you that are new here, my name is Tanya Pintado, and I'm one of the wound and ostomy care nurses here at the University of Miami Hospital and Clinics. It is my pleasure to be your host for tonight. But before we begin, I did want to mention that during this session, you will have the opportunity to ask questions. One way to do so is by using the raise your hand feature. It will be located at the bottom of the screen. You will be unmuted and you'll have your chance to speak with the presenter. The second option, for those of you that do prefer to stay a little more behind the scenes, you are able to type your question in the Q&A box that's also located at the bottom of the screen. Now, without further ado, allow me to introduce to you our speaker for tonight. So Dr. Munoz was born in Medellin, Colombia. His academic background includes 5.5 years of medical school with 1 year of internship at UPB in Medellin. He has experience in emergency medicine and has assisted in surgical procedures in the pediatric population. In 2005, he specialized in general surgery. As a general surgeon, he assisted in colorectal surgeries and their clinics. He has performed numerous abdominal wall reconstruction surgeries, along with surgical management of pathologies via laparoscopic or open. He is a teacher at various universities for residents that are currently in their general surgery residency program. Without any delay, I will have Dr. Munoz take the floor.
Okay, hi, thank you. Thank you for the introduction. It's a pleasure to be here with you. I'm gonna share my screen so we can go to the presentation. So tonight we are going to talk about parastomal hernia. First of all, we need to understand what is a parastomal hernia and how to deal with it. What is a hernia? A hernia is a defect on the muscular layer of the abdominal wall. Everybody may have a hernia, and we can be born with it, but we can also have secondary type of hernia, which is those created or those that form after an incision or a surgery, or may be related to other procedures. So whenever we have a disruption in the muscular layer of our abdominal wall, we may develop a hernia. Here we see some of the inner layers of the muscular wall and some of the inner contents of the abdomen coming through it beneath a surgical wound, a previous scarring surgical wound. So at this time, we can call this an incisional hernia. What is an stoma? An stoma is an opening of the bowel to the skin. And we may have these openings related to trauma, related to many diseases. And that's why I say we have multiple techniques to do this. And we may have ileostomies, colostomies, and they may be temporary or definitive. So we have to decide whenever we have these problems and this type of stomas, how can we deal with them and what is the need to still have them? So if we put these two concepts together, we have the parastomal hernia, which is a hernia that allows the contents of the abdominal cavity to go through the abdominal wall, but not over the skin. And when we have an stoma and a hernia related to it, we have the abdominal contents coming through, accompanying the stoma, but not going out of the skin. So this is a frequent complication in many of the patients that had stomas. It can occur in up to 78% of the cases, and they always develop within the 2 first years of having an stoma. So we here see some examples of parastomal hernias. And there are many ways that you can consult on us to try to find out what is the case, how is the hernia in these cases, and we have to do many things to diagnose these conditions. As I said before, the abdominal contents most likely the small bowel or the large bowel may come through the opening on the muscles, and they can be the component of the hernia sac. So how do we diagnose this type of hernia? Sometimes the physical exam is more than enough to complete the diagnosis and to know what are we dealing with. So patients that had bulging next to the stomach site and has a mass filling may have a parastomal hernia. So the surgeon or the doctor may check this site, do a physical examination of this site to see if there is an opening on the fascia or the muscular wall, and we in that way can see if there is an hernia or not. If we can do that, but we still suspect the presence of a hernia, we may ask for many other symptoms like intestinal blockade that can happen occasionally, but the patient always feel some difficulties to have bowel movements through the stomach, and sometimes is accompanied by bloating, maybe burping, or maybe vomiting. So when a patient is already vomiting related to this condition, is a medical condition that requires the patient to go to the doctor, maybe to the ER to be checked and to do all the diagnostic tools that we have to compete with this. So at this time, we can talk about some medical helps that we have to diagnose this, like the ultrasound, the CAT scan, or the MRI. The ultrasound will allow us to check, the radiologist to check on the abdominal wall and to see if there is any defects or any content of the abdominal cavity going through the abdominal wall. In that case, they can let us know how big is the hernia and what is inside of the hernia sac. But more complete examination will include the MRI or the CAT scan. The CAT scan will allow us to see, like in this case, in orange, the ostomy loop that is going through and that we pretend to have over there, but the green painted loop is not supposed to be there, as well as the pink painted region. There is some of the fatty tissues that are into the abdomen, but are not supposed to be outside of the abdominal wall, which in this case is painted in blue. As well as the MRI, this gives us great information for surgical planning, and this gives us great information to know what's going on and how to deal with it. What are the symptoms? So the patient may feel an slow onset of symptoms because, as I said before, this is a condition that is going to be building up in the first 2 years, most likely, of the patient having an stoma. Some people may feel some pain or discomfort, but as long as it doesn't have a complication, you may not feel the bulging, you may not feel the burping, you may not feel the vomiting, and you will have this pain or discomfort coming and going in a non-continuous basis. There are many people that doesn't have pain, but they experience a difficulty to keep the stomach barrier in place. And they feel like the stomach barrier is not lasting as long as it's supposed to. So at this time, it's important to seek for medical help. There are risk factors that may bring an hernia most likely to the patient and may be related to hernia formation. Those are elderly. These first risk factors are some things that we cannot change. We cannot change the age of the patient that we are seeing. So elderly, because of the softness and the lack of force that is getting there in the tissues of the patient, is nothing that we can modify about that. So elderly is a risk factor. Central obesity, which means having a big belly, the personal history of cancer and cancer-related surgeries, inflammatory bowel disease like Crohn's disease, respiratory illness, because when people is getting some shortness of breath, they start using abdominal wall muscles to compensate. And that doesn't let the surgery heal. At that point, it may create a hernia related to the ostomy. And previous hernia presence or previous hernia repair will leave the abdominal wall in a lack of a current and proper dynamics for healing, so it may contribute as a risk factor for formation of hernias. But there are another risk factors that we can change. We can change the nursing factors related to the patient. We can change malnutrition. We need the patient to eat properly, to lose weight, to eat the proper nutrients that they need for healing. So we have to give some advice to the patients to eat properly and to leave behind fats, to leave behind gluten or some other factors that may contribute to poor healing and may contribute to poor inflammatory response. Smoking is really important, and we have to quit smoking before having a surgery, because smoking will not let the tissues oxygenate the proper way. And if we don't develop that characteristic for the healing and scarring of the tissues, we are getting a higher risk of developing a hernia. Chronic coughing and chronic constipation may be treated. When they may be treated, we better treat them to reduce the risk factor, to reduce the chances of getting a hernia. Corticoid use whenever they're possible, prevent surgical site infection. That is really important, and that's why we give a course of antibiotics before the surgery and during the recovery days. And if we can, we have to combat obesity before the patient goes to surgery, because the tissues will be more prone to proper scarring and proper healing than those in the obese patient. What complications can appear into the hernia presence? So the most common complication is cosmetic, because it seems really weird. It seems like you have a deformity. The patients have to deal with something that is bulging over the clothes and is visible. But the serious complications are having your guts trapped or twisted, and they may lead to suffering of the abdominal, of the intestinal, or the intestinal loops, and strangulation, which is surgical emergency. And if that happens, patients may need to be taken to the OR, but it only happens in less than 20% of the patients. So that is important to note, that as it may happen, it is not likely to be the most common complication. The most common complication is cosmetic. So there are multiple strategies to treat parastomal hernias. The most common things that we consider for the patients are lifestyle changes. We have to change the way we eat. We have to change the way we smoke. Smoking is a really big problem for our patients, because the more you smoke, the more years you have been smoking, the poorer is the abdominal wall healing. So we have to try to quit smoking as soon as possible, as we know we are going to get a surgery. And if we're getting an stoma, it is important to quit smoking for a long time, and definitely to prevent complications related to smoking. Another strategy is to use an abdominal binder or abdominal belt that will prevent the pressure of the abdomen to go over the hernia site, and in that way we can have less abdominal pressure pulling through the hernia site or pushing the guts out of the content, and in that way we can prevent the formation of parastomal hernias. So there are another strategies to treat big hernias, and those are closing the stoma, primary hernia repair, relocating the stoma, or mesh repair. I'm going to go over this really quick. The stoma closure. We may close the stoma whenever is possible. If the patient has a definitive stoma, we may not take it down. But if it is an stoma for protection, an stoma for diverting the intestinal content for a disease, but now the disease got better, we may take the stoma down and reconstruct the intestinal anatomy. In all cases, taking down an stoma is a major surgery with major risk. And we have to see that the intestinal integrity is there, that everything is correct, that the patient is not going to be having major complication or problems related to the closure of the stoma. And we have to do a proper surgical planning, which includes nutrition, which includes quitting cigarettes, and all a series of exams and preoperative assessment to take the patient in the best possible way to surgery. There are many techniques to take down an stoma, and in these techniques, we may staple or suture the guts or the intestines together. So we need a good healing from the patient to be secure at the final result of the surgery. Just closing the hernia, whenever the patient is not able for medical conditions or for its diagnosis to have to take out or take down the ostomy, we have to close the hernia. In this case, we are going to close the abdominal wall, and we can reinforce it using a mesh. The primary closure is to take down, put the stoma away for a while, close the abdominal wall, and then take the stoma back into position. We have to select the patients in a proper way. We have to study how big is the defect and what is going to be the best strategy for this. So this technique has a higher infection risk, and we have to select the patients in a proper manner. Relocating the stoma. We may relocate the stoma, as we see in this picture. There was a stoma site, maybe for the hernia, that was over there. Everything was taken down, and the stoma was placed in another nearby space. And the primary site where the hernia was closed with or without a mesh, and we have to make sure that the stoma is far enough to let all the the barriers to sit well, to not interfere with the previous wound, sorry, and there is a high risk of infection, and both sides will have a higher risk of hernia. As I said before, having a previous hernia will be a risk factor to develop a new one. Mesh repairs. So we may put a mesh to prevent the hernia formation and to close the hernia. This is a laparoscopic example of a mesh repair, which is called the sugar baker technique. It can be also peritoneal, which leaves a mesh with no contact with the abdominal content. It can be done open or laparoscopic. So this is a good example of how can we operate, and it brings a secure procedure to the patient that lasts longer and is secure enough to not make anything go wrong, or is secure for the patient to be taken to surgery with a good cosmetic and functional result. This is how we do it, how we place the trocars, and how we put the mesh in place, closing first the site of the hernia. So this is an invitation to have a full life, no matter stoma, to enjoy life, to have a great quality of life, and to behave like a normal person. Having an stoma is not a punishment. Having an stoma is not limitant to do whatever we want. I also put these two examples. This guy was taken to ileostomy related to Crohn's disease. And after that, he decided to change the way he ate and the way he worked out, and he became a bodybuilder. And he's famous because he is a champion in bodybuilding, despite his ostomy, in his ileostomy actually, and he's been doing great, as well as this girl who I forgot the name, but I used to remember it in the previous weeks, who is a champion in bodybuilding, and she also had an ileostomy, and she did it all after the ileostomy, and she's doing great. So I want to give my last thoughts on sexuality, which is something that may be an option for our patients. We don't have to forget about our lifestyles, our things that we love, the things that we do, because there are many appliances that we can put on the ostomy bag. There are many things that can be a complement, but not a limitant for our personal development. I have always had the United Ostomy Association of America support, as well as the group has it. And I want to thank you all for assisting to this presentation. And I hope you enjoy it. I'm open to questions, and I'll try to respond everything as swift as possible.
Thank you so much, Doctor. That was a very good presentation. You did make some very valid points, especially when it comes down to the appearance. Many people that have hernias have a difficult time trying to conceal it, or maybe they feel that everybody else notices the hernia, when in reality, not everybody can tell. But there is certain changes that one can make to help conceal the hernia and just make it a little less noticeable. Because the hernia can be at the stomal level, which is usually on the lower abdomen, when you have a hernia, it bulges out even more. Sometimes with a two-piece system, it is kind of like high profile. So you'll have a two-piece system, and it doesn't mold very well to the contour of the abdomen. So now you have this pouch kind of poking out even more, And when it fills up a little bit, it pokes out even more. So there is different approaches and different appliances that can be used with a peristomal hernia. I know many individuals do prefer the two-piece system. So if you are somebody that maybe is beginning to develop a peristomal hernia and they feel as though the two-piece is poking out through the shirt just a little bit more, the Coloplast Flex is a two-piece system that molds to the contour of the abdomen, and it does help conceal the hernia even more through the outside of the clothes. So it is a good option to have if you are somebody that does prefer a two-piece system. Just keep in mind that when it comes down to the two-piece system, not all of them, the one-piece systems, not all of them have the hooks for the belt. So if you are somebody that needs a belt, we'd have to find the right appliance for you. But Coloplast also does have a one-piece, and Hollister does too, that are very, very thin and low profile. So they do happen to mold to the shape of the abdomen just to prevent it from protruding even more. So these are good options to have. I did want to bring up that you had mentioned increased pressure in the abdomen can lead to hernias. And that's a good point. And especially now with COVID going around and people getting sick and sneezing and coughing, all those little things do trigger high pressure to the abdomen. And that is something that can contribute to a hernia. So it's very good that if you do feel a cough and you happen to have time, or you feel a sneeze, grabbing your hands or even a pillow to kind of support that area can decrease the risk of developing a hernia. And it's something very easy. So you just grab your hands and you're able to cough or you're able to sneeze if you need to. But the most important thing that I did want to mention, if you are someone that has a hernia, it's very important to monitor the different signs and symptoms of strangulation, which is a complication that can occur. And I know that you had covered that as well, Dr. Munoz. Pretty much, you want to make sure that you have output and that you have gas in the bag. Those are just two ways to really know that there is still flow through the intestines. If you begin to feel severe pain, not a regular discomfort that you may have felt before with the hernia, but a more severe pain or distension as well, you do want to contact your doctor and go to the emergency room as well, because those are all signs of strangulation. And then on the outside, if the stoma turns from a red to a now dark purple, brown, purple color, a maroon color, you really want to monitor, because that can really mean ischemic changes. So now there is no more blood flow going to the hernia. So that is the most important, one of the most important things when it comes down to a hernia. All right, and then I believe that we do have one question. Can a hernia reduce in size?
Well, actually, a hernia cannot reduce in size. Actually, the most common thing that happens over there is that the hernia is increasing in time. As long as there is a hernia, there is a pressure on the edges of the muscular wall, and it will retract even greater year after year, and it will become bigger after the time passes. So there are no evidence that the hernia can reduce in size, but we can use the proper abdominal binder or maybe a belt to help the hernia to stay inside, but not to increase the size. But it is almost impossible to reduce in size. Tanya, your mic.
Can you hear me now? If you check in the chat, we did place a link to a hernia ostomy hernia support belt. This is one of the more cheaper ones, but it is still very good quality because hernia support belts can range up to the hundreds of dollars. So this is a very good alternative in the meantime, and the link is there below. We also have a question from Marilyn, Israel. Marilyn?
Okay, Marilyn
Does
was
this information apply to a hernia near a urostomy?
yes, it's the same mechanism of hernia formation, and it's the same strategies that we have to prevent and to treat this type of hernia. All the ostomies are basically the same, despite of different diameters, but the mechanism in which the hernia is formed is related to the abdominal wall and to the muscles and to the pressure. So it can happen in any type of stoma, as well as urostomies, ileostomies, colostomies, and the treatment will be the same manner.
May I ask a question?
Of course, Gilda, go ahead.
Yes. Do I need to be measured in order to purchase a girdle, or that restraining device that I saw on one of the part of the presentation? Can I go to a store and buy one? Where is that store? If that is.
So the link that I sent, it is an online store and you are able to purchase it through there. If there is another option, if you were to come to the ostomy clinic, we would measure you for a custom made belt. So we have to measure you laying down, standing up. We get different measurements and we're able to make you a more custom belt for better support of the ostomy. However, not all insurances cover that. So you may have to purchase it out of pocket. That would be called the New Hope belt. If you are looking for something a little less expensive, another option would be the Brava hernia support belt. That one we can also fit for you in the clinic if you'd like, because we'd have to measure you, cut it out to the size of the ostomy.
Can you still hear me?
Yes.
Okay, I'm sorry. I know it takes a while to get an appointment to be measured. And in the meantime, I don't want my hernia to grow,
Right.
get larger, or to get worse. However, I prefer, even if I have to pay for it, the one that is fitted to me, because obviously I assume that would be best. How could I do that?
Okay, so if I can always move up the appointment for the clinic, that's not an issue. And we can always measure you and get you a custom belt. We would put in the order and the doctor will sign it, and then we will send it to the medical supply company that is currently supplying you with your ostomy supplies.
I don't have enough.
Yes, I'm working on you.
Okay.
Don't worry.
I'm buying them.
I haven't forgotten about you.
Okay, please.
Yes,
push up my appointment this time.
I'll call you
I'm
tomorrow.
afraid.
Don't worry. We'll move you up.
Thank you.
Of course.
Is there a possibility to develop other hernias? And I was typing, but I don't know how to send this to you. So I'm sorry that I'm asking too many questions. But can you, once you have a hernia, and the hernia is around the ostomy.
Yes.
Can you develop others? And if you are developing other hernias, how could you prevent? And how about nutrition? What nutrition besides the one that was given at the hospital of, what was it? No seeds, no certain things that would cause more diverticulitis problems. How could we have access to a good nutrition for this? I was impressed with that young man and young lady who were in bodybuilding.
Oh, yeah.
Like to be there.
Yes. Our last
I
speaker was a personal trainer. The one that's coming next month, she's going to be a registered dietitian, so she will be talking about nutrition as well.
next week.
But essentially not straining on the abdomen. So making sure that you're drinking plenty of water, that you're taking fiber so that that way it kind of it's able to come out easier through the pouch. As far as making sure that your hernia doesn't get worse, being mindful of certain activities and movements that may cause intra-abdominal pressure. So like I had mentioned before, sneezing, coughing, something as simple as getting in and out of bed. Think about when you're laying flat and you're ready to get out of bed. What do? You put lots of pressure on your abdomen. So just making sure that if you're going to get out of bed, using your arms a little bit more, not lifting things that are very heavy. That could be from 5 to 10 pounds, whatever the surgeon says clears you for. Just any technique that reduces the intra-abdominal pressure. Once you have a hernia, you are at risk because that's weakness on the abdominal wall. So just being mindful of those certain movements that may increase the pressure on the abdomen.
Thank you. Thank you very
You're welcome. All right. So the next question is going to be from Miriam Bonich. Miriam?
Can you hear me?
Yes, we can hear you.
Okay. Well, I live, unfortunately, with a very large parastomal hernia. I've been living with an ostomy now for a little over 4 years, and unfortunately, it's not something that will be reversible because I am a anal cancer survivor. And after radiation therapy, the sphincter muscle doesn't work at all. I'd rather live with a bag than in diapers, to be honest. But I've already seen, I have my colorectal surgeon, is it from the University of Miami. I'm also seeing a reconstructive surgeon there who, as a team, are going to work together and they're going to repair the hernia, move my ostomy, and they're also repairing a ventral hernia that I have. But I'm trying to lose another 30 pounds. And I'm a type 2 and my sugar now is at 6.7. It was very high and I finally got it together. I'm going to tell you honestly, I'm really scared of the surgery, but I want to have it done because I don't go anywhere. I don't do anything. I'm so self-conscious. And I have a hope belt that I had made with you girls with, I forget her name now. The other girl, ay Dios mío. Anyway,
We have
who
a
I love.
few.
Okay. Anyway, who I absolutely love. And how long will my recuperation? How long do you think I'll be in the hospital? Because I know that the first of all, I know the incision is huge because they have to repair the one on the ventral hernia too. But they told me maybe a week, but honestly, I'm really scared, but I'm also scared to continue living like this because I'm miserable. I really hate living with this. I look like an old lady with white hair who's got a side pregnancy going on. That's what I look like. I have a side pregnancy. But anyway, I know all the risks and everything because I've seen already 2 plastic surgeons at UM, and the second one I saw, she made me feel a lot better, and she told me I could take care of it. You might get it again though. I said great.
Right.
So anyway, and I really need to see somebody to, I don't know, my stomach gets, I get upset stomach all the time. I have no problem with the flow at all. It works. I get gas. I get the whole 9 yards. But
Good.
I don't know. It just seems like every day there's something less I can eat. because so many things make me sick so easily. But anyway, the main question is, how long do you think I would be in the hospital with something that major done?
Well, actually, you have two major procedures going on, the ventral hernia and the parastomal hernia. And if they're doing this together, you may be in the hospital for around 5 to 7 days if everything goes well. It
Okay.
depends on the technique. It depends on the expertise of your doctor. But I'm very confident that you will be there as long as they told you already, about a week, which is the recovery time usually taken for this type of surgeries.
Okay.
Yeah.
Then that's including moving the stoma as well, because I have to
Yes.
live with that.
Yes.
Okay.
So you will have two abdominal wall repairs, which is the ventral hernia and the moving stoma technique repair. But then you will have a new stoma in a new site, and those other two sites will be healing, and it will take about, as I said, 5 to 7 days to recover. And it's really important to modify the risk factors that you have, like the type
Right.
2 diabetes, and as I said before, eating properly and smoke.
No,
And
I don't
smoke,
smoke. I don't
yeah,
smoke.
and quitting cigarettes is important in
Right.
cases that the patient smokes as well.
Yeah. Okay. All right. Well,
You're in good
I guess
hands.
I'm sorry.
You are in good hands.
Oh, I'm so happy with my doctors at UM.
Mm.
I'm very confident with them. I just I'm exhausted living with a hernia this big, but and I do have a belt as well, a hope belt that I had done. I was
Yes,
measured for. So,
one of the
but
things that they are seeking with this type of surgery is to bring you back to a good quality of life setting. So it is really important because, first of all, you're a human. First of all, you have a living to do, you have things to do, and you have to live your life fully. So
right.
the best way to take away that side pregnancy and to become back confident and to do the things that you are supposed to do and that you want to do is to have a good abdominal wall repair. That
Yes.
is important.
Okay. All right. Very good. Thank you, doctor, so much.
My pleasure.
Good thing is that if you have the surgery here, I do know that often PT will see you after, physical therapy will see you after, and they are able to help you, with the body mechanics. How do I get in and out of bed? How do I stand up? How do I do certain techniques without increasing pressure, again, to just lower the risk of developing a hernia? And you're
Well,
already on the right track because you're lowering your A1C. So that's very, very important,
oh,
especially with
it was very high, and I didn't have any idea. But um, yes, good doctors and a lot of drugs. I have to say, I, I'm lots of drugs and great doctors. I mean, between Baptist and UM and the Miami Cancer Institute, it takes a village to keep Miriam above ground here. But anyway,
we prefer it that way, don't worry.
no, I'm really I'm very grateful to all the wonderful people, especially the nurses that I have met. Um, I believe Ana Restrepo was the one who did everything for me,
Yeah,
and she did
Ah,
all
yes.
the
Anna.
measurements and everything, and she really changed the way I feel about living with an ostomy, because I used to have the most horrible accidents all the time, and now I can handle it. It's just the hernia that's really the worst part now. Hopefully
But
before the end of the year I'll be doing this.
once you get the repair, you'll see the quality of life will improve. You just have to
I
think about it, that the benefits are going to outweigh the risks. That's the best way to say it.
Well, you're right. I mean, I was scared. I thought, oh, can I go through this? And maybe I should just live like this. But no, I can't. I just can't live like this. Living with a parastomal hernia, mine is very large, is debilitating to say the least. But anyway, thank you so much. You guys are wonderful.
Of course,
I
thank you.
really, really enjoy these meetings that you have, and I learned so much from all of it.
Good, good. That's the idea. Thank you so much. All right, so we have another question, which is a very, very good question, actually. Must all hernias be repaired?
Well, actually, as a general concept in surgery, all hernias must be repaired, but we have to take each patient in an individual context, and in that way, we can say this surgery is too risky for you. This surgery is a common ground for you. So at this time is likely to lie down. The answer to that may lie down in your individual characteristics and your doctor expectations for this type of surgery. But as a general concept, all hernias must be repaired.
Right.
Remember, they only grow bigger.
Right. Especially if there's complications involved with it.
Yes, and symptoms.
Right.
Whoever got symptoms must have a surgery done.
Hello.
Hi.
Hi. I had a surgery back in 2020 for the whole hysterectomy, a complete hysterectomy. And after that, I developed 3 hernia. I don't remember the name of that, but I know that one is umbilical. And there was one very close to the, how do you call that? Well, I went to a doctor because before I have now the coloscopy, I went to a doctor in University of Miami, and he recommended, because of my age, and I'm 73 years old, and the way the hernias were, it was less complicated if I don't touch it. The problem is now, because of the coloscopy, I developed another hernia. So right now I have 4 hernias. And my stomach is not like a pregnancy thing, but it's like bump everywhere. Plus they bother me. They bother me when I walk. They bother me when I sit down. They bother me when I cough. I cough and I don't know which one I'm supposed to support first, because I have it all over my stomach. I don't know if he didn't want to do any surgery because I was going to have a cancer treatment.
Oh.
And I know that when you have a cancer treatment, the way that you're supposed to heal is very bad, but I haven't got anything since March. I don't expect to have another cancer treatment unless I have, it comes back again, which it came back twice already. But I really don't want this hernia. I don't want it. They look very awful. I expect them to fix my coloscopy and have it back maybe by the end of August or the beginning of September, that they were able to connect it back into my body. And then I would like to have my hernia, taken care of.
Yes, actually, there's a really common ground for many patients, because as I was saying, there are many individual things that we have to consider, like cancer treatment, chemotherapy, radiation therapy may bring complications related to the surgery. So there are prudency times. There are times that may be respected to let the body take out all the risk out, metabolize all the things related to chemo, all things related to radiation therapy. And after a while, if everything is going all right, we can reconsider taking you to surgery. So you have to discuss this further with your doctor. So because the time after he takes down the ostomy will be the greatest time to take care of the hernia after that.
Oh, that would be, because I don't think being 73 years old, I'm supposed to live with this.
No, it is not fair to say that. It is not fair to say that you have to live with a hernia or an ostomy just related on the age. You have to live with many things related to the medical condition, but if the medical condition can be improved, you may be suitable for a good surgery and a good hernia repair and a good ostomy reversal surgery.
Not only that, I already have an obstruction back in May, and I don't want that. I don't want to live with the anxiety of having an obstruction every time I have a stomach problem, because it could be just that I ate something and it didn't come out very well. And that doesn't mean it's an obstruction, but the obstruction is in my head now. And
Right.
that's what I want the hernia to be, fixed.
Right. Are you wearing an abdominal binder or any type of support?
Well, that
your
I
abdomen?
already, Anna came out with that, and I already have it.
Oh,
I have
good.
it. Yeah, I got it on Friday.
Oh, you
So,
just got it. Okay. When
yeah.
are you wearing it?
Well, the first day I wore it like the whole day, and I didn't do good. Apparently, because it was the whole day, and I really tied it. I tied it. I thought that maybe the tie was the better. And at the next day, I didn't feel good.
Okay.
My whole stomach hurt.
Right. You want to be comfortable with the belt. You don't have to tie it so tight that it looks like a corset when you're wearing a dress. You just want
I
it to
look
be
very
more-
good.
Yeah. I don't doubt it. You just want it to be more of a support, so I do always say, like, if you're out of bed, it's a good time to wear it. But if you're going to be out of bed and kind of just maybe sitting down, not doing much, you don't necessarily have to wear it, but definitely when you're out of bed and not too tight.
Not
Not
good. And how long? My husband said wear it like maybe 3 hours today, and then 2 hours tomorrow, or whatever, until your body get used to that.
Right. It is an adjustment. It is an adjustment, especially if you're somebody that's not used to having to wear anything on the abdomen except the appliance. So that is kind of a good idea to taper it on. Again, if, for example, it's a Sunday, for example, and you're not going to do much, you're just going to hang out on the sofa, maybe watch some TV, you don't necessarily have to wear it. But if you're going to be active that day, if you're going to go to the store, grocery shopping, anything like that, you want to consider wearing it until you get used to it. It does take some time. All right, and Natalie, I see that you have another question. I didn't forget about you.
Okay. I have, number one, I have a double ostomy, one on top of the other. And I'm so glad he explained what a hernia was. I thought it was, I have them both on my right side. And I thought the hernia was on the left. It's not. My hernia, according to it, is underneath my colostomy, but not the urostomy. I do have a belt with double hole from Hope, New Hope. But since I have a double ostomy, it's very, very wide, and it can be very uncomfortable. And men have a very straight body. Women have curves. So when you put an ostomy belt on that's 9 inches, it's very baggy on the top. Is that normal? I mean, I try not to make it too tight, and I wear it when I'm lifting anything and stuff like that, but normally I don't. And my question to him was, he said everyone should have a hernia fixed, but this is so from Karen Law, it's a small hernia, and I'm very careful. And does really everyone have to have hernia? Like, would it be more complicated since I have a double ostomy, one on top of the other, to repair a hernia?
Well, that's a good question because, as I said before, everybody should have a hernia fixed. In general concept, as I said, when you diagnose a hernia, you offer surgery, but you have to take the context of every patient with you, and you have to put in context everything so the patient is safe. If the hernia is not hurting, is not bringing
No.
up complications, is not something
complications.
that concerns you as a patient or concerns your doctor, you may live with a hernia as long as it doesn't bother you, and as long as it doesn't represent any danger for your health.
Okay.
And
Okay.
using the belt and preventing the hernia to grow is the thing that you are doing is the things you are supposed to. So
And
you're
I'm good.
doing
I thought the hernia was on my left side where there is nothing because they took the whole muscle. But watching what you say, I said, oh no, it's right by the stoma. Because I kept this, I don't have a hernia. It's all loose. There's nothing there. But it's the other side.
yeah,
So
it's on the side of the
it
stomach.
is a small bulge. The nurse said it was, I did have a parastomal hernia. I wrote to write it down because I didn't know what it was. And she did measure me for the New Hope, and you have to lay down and lay down for a few
Yeah.
minutes and measure. And I keep a copy of it. I brought the plastic Ziploc bag. I brought two of them. One goes to New Hope and one I have. So I always have the measurements.
That's
Awesome.
great.
Yeah, have them with you.
I
Yeah,
have it.
Keep them close in case you need them. That's
Right,
great.
and also the bag, they have it at my supplier. I have a special code because they know which one is mine only. So when I reorder it, this is the code they order for NB Herbin with the name, and they have a special model.
Yep.
Yeah, that's really important because the industry, the barrier industry, give us many chances to improve, and those are confection for every patient, sometimes in a different manner. So having your own type of barrier and having your own devices will help you to keep it that way and to keep you out of surgery, out of the need of surgery. So that's great. You're doing great, Natalie.
Yeah, I mean, I was in a hospital for 52 days. I had 3 surgeries because unfortunately, I got COVID, and I don't want to go back in the hospital for any more surgeries if I can help it. I saw enough nurses and doctors at Sylvester for my rest of my life.
You're
That's all
okay.
right.
You're okay.
May
No,
I
but
ask
you have
another
to say,
question?
okay, sorry.
No, go ahead. Go ahead. Finish before I ask the next question because it's just.
I'm done. It's
I
okay.
just
It's all
want
yours
to
now.
know. I just want to know if this video or this presentation, as well as previous ones, can be accessed because I could use all the teaching.
Yes. So Gilda, actually, as of last month, Anna was finally able to upload all the recordings to the website that we have. So at the end of this presentation, I'll go over the website. You can easily log in there, and you'll be able to find all the recordings of the past ostomy support groups as well.
Thank you
Fantastic.
very much.
That's
You're
great.
welcome.
Great. That's great.
Problems and solutions. All right. So with that being said, we're going to wrap up today's presentation. But before we end the meeting, there is a couple of announcements that I would like to make. Mark your calendars because on August 2nd at 6 p.m. Eastern time, we will have Jessica Moya. She is a registered dietitian, and she will be speaking on nutrition with an ostomy. So I know many of you were interested in that topic, so this would be a great presentation to see. If you or anyone you know feel as though they would benefit from the Spanish ostomy support group, we also have one. It takes place on the third Tuesday of every month. So the next one is going to be on July 19th, and Dr. Mingier is going to present on peristomal skin damage. We are also starting to plan our second annual Ostomy Awareness Day. So please save the date. The event will be held on October 1st, and there will be more details to follow. If you are interested in seeing the previous videos, as well as the upcoming meetings and ostomy events, you can always write your email down in the chat, and we will be sure to add you to our emailing list. If you want to see the videos, you can go to umiamihealth.org and click on the support tab section, and you will see everything there. I wanted to take this time and thank Dr. Munoz for giving us such a great presentation on peristomal hernias. I feel like everybody was able to take away some new piece of information regarding this, and hopefully a little bit of ease of mind, some peace, that we will get things resolved. So thank you for that.
My pleasure. Thank you for the invitation.